And after that, of course, I'm a wife. And I'm the mother of Christopher, my 20-year-old beautiful son, and all the family and friends that I belong to. So that's who I am in this world, and this is what I do for a living. So they're all together, right? They're all a package deal. And so I was very grateful to be invited here today, and we'll start the presentation. But today, I was invited to talk about our health as women. And that's a broad subject, right? So how do I do this? But with some guidance and some discussion about what was important for today, we decided to break this down into what do women need throughout the decades of life, right? And so if we can go to the next slide, I thought I would start first with how do we define health? And I'm using here the World Health definition. It's a good organization to trust, by the way. So I like what they say about health. Health is the state of complete physical, mental, and social well-being, and this is where it's important, and not merely the absence of disease or infirmity. Take a moment to let that seep in, right? It's not because we don't have diabetes or we just don't have high blood pressure. That's part of it, but it's all of that together and how we live in our environment, how we interact in our environment, how we interact with our family and our community. So all of that is health. And then the next one tells about wellness. So health and wellness go together. They're just a little different. And wellness is defined by the World Health Organization has two aspects. One of that is achievement of an individual's fullest potential, physically, psychologically, socially, spiritually, and economically. Whew, that's a big thing, right? That's all encompasses wellness. But I may also ask you to engage with me in the conversation, so don't be shy if I do ask you questions, and it's just for us to, get some activity. So when we talk about women in their years, the decade of 20s and 30s, and I just have a curiosity, how many of us are in their 20s or 30s in here? There you go. There, awesome. And then how about 40s and 50s? Okay. You want to join me in the 60s and 70s? There we go. So this is where we are. So we're good. We're all represented today. That's awesome. So what should, and this is where I'm asking you to help me, just get some conversation here. What do you think should be some of their health goals in the 20s and 30s? So those of us in the 40s, 50s, and 60s, if we look back, which would be doing to our younger individuals here? Which we've done, yeah. Pap smears, yes. What else? I'm sorry, I can't hear you.
Scanning for cancer.
Oh, yeah, screening. Yes, in 20, we start with pap smears, absolutely. Eating well in our 20s and 30s. Exercise in our 20s and 30s.
Fertility health.
Yes, very good. Fertility health, staying healthy ourselves.
Being regular within physicals.
And get physicals. Yes, so all those. So it starts in our 20s, right? It doesn't just start all of a sudden, oh, I'm 32, let's go get something done. Awesome, you guys hit them all on the mark. Okay, our next one, and we said exercise. Now, how much exercise do we need? According to the Centers for Disease Control. So I'm not going to be the one to get in trouble here. We'll put the responsibility on somebody else. So how much should we get every day? Oh my gosh, you guys said yes, 30 minutes, but we're going to add one more time, it's 5 times. So 30 minutes, 5 times a week, which is a total of 150 minutes. So very good. And pap smears, okay, we should be getting our pap smears, and then next we should be going to our doctor's office. Pap smears actually start at age 21, and then they continue, the thing about pap smears. So they start at age 21, and most of the time when you get examined, when you're in that decade of the 20s, you will be checked as well for gonorrhea and chlamydia. Don't be upset with that, they're just part of what we do. And it's actually really important because unlike men, who if they were to have this infection, they are very symptomatic. It is painful. So they're gonna run to the doctor's office and get treatment. That's not so much for women. So almost 70% of women who might have this infection don't have symptoms, right? Only about 30%. So they might be brewing this infection for a long time and not even know that. And the problem that we need to attend to that is because those infections affect our fertility. they cause fibrosis and scarring in the fallopian tubes, and then later when you're trying to get pregnant in your 30s or so, then it's difficult. So it's actually a good thing that we screen for that with the pap smears in that decade of life. Okay, then we go to the next one. And after that, when you do that, you should be going to the doctor to talk about screening for diabetes, and we go to the next one, and screening for cholesterol, and then the next one, vaccines. Then we can just put all the vaccines that we need. So in the 20s, if you didn't get the 2 or 3 vaccines, there's an age group in when you're an adolescent. If you get it before you're 15, you get 2, and if you get it after 15, you get 3 vaccines for HPV, human papillomavirus. And that's important because that's the virus that does affect the cervix, and that's where cervical cancer comes from. And everyone has a personal perspective on that and whether we're going to be able to do that, but it does prevent cervical cancer. So at the end of the day, it would be a good thing to get those HPV vaccines. And then we get the tetanus, diphtheria, pertussis, and depending on who you are, you might have someone that has asthma. You might be someone that unfortunately has been diagnosed with a condition in which you're on prednisone or some other reason that decreases your immune system. So for you, you should seriously consider getting the flu and the COVID vaccines, because if you were to get sick with those, it's usually a higher risk. Mm-hmm.
If I can back up to the HPV
Vaccine?
yeah, the HPV vaccine, because I just became aware that there were more than one type. It's more than one type of HPV.
Yes.
So does the HPV vaccine cover all of the types?
No, it covers the most prevalent and the most likely to cause cervical cancer. 16, 19, 34, 36, 37, something like that. But yeah, so there are various types, exactly. And so that vaccine does cover the most prevalent types. Yeah.
And it's good to know also because
Yeah.
most people that I talk to only associate it with sexual activity. But you can get it through fungus from my understanding from the nail salon or something like that, which is one of the types that in my research that I
The most common HPV types that cause cervical cancer are from sexual activity.
Thank you.
Bottom line, that's just the way it is. And the thing that they've done recently is they've extended the age out to initially age 26, and then I was doing some reading not too long ago, and they've actually increased it up to age 45. So so some people, maybe postpone having sexual activity, and so they're still able to get the vaccine, or some just started sexual activity. So I don't really see a lot of people getting in their 45, but they can, and that's like a one-on-one discussion. What are your risk factors? What's going on in your life? Do we need to take care of this for you? And then we'll decide together. But yeah, it's important if you can get them. And everyone's a little different in terms of our belief, especially in younger people. And I guess I can share this with you. My husband and I were at two opposites ends. I said, no, my child's not getting that HPV vaccine. He's only 14 years old. I was very adamant about it for my personal beliefs about that age group and what do we do and what we don't do, right? And I don't know, I guess he felt differently. And next thing I know, he's taking our child to get the vaccines because he was coming from a different perspective. And, it was fine. My kid said, no, I want it now because I only get 2 vaccines, Mom. And if I get it later, I get 3. So that was his perspective on my then 15-year-old. All right, next one. Okay, so the pap smear. A few words on the pap smear, so we'll go there. So like I said, the pap smear is routinely at 21. It ends at 65. Yay, I'm 65 next year. We're done after that, In your 30s, if it's combined with the human papillomavirus testing, which is done simultaneously at the time you collect the sample, then you can go every 5 years, right? And that's amazing. So instead of going every year, which used to be the case 2 decades ago, then we went to 3, but now in your 30s, if you add the HPV testing and your physician does that for you, it's every 5. I think that's pretty nice, time to do that. Okay. And of course, it is that to detect precancerous conditions that may lead to cervical cancer. Okay, the next one. All right, so we're just going to read the board together, but this is, again, 30s, 40s. A lot of that information is what we already did, right? All that here. So really the only new is that age between the ages of 40 and 50, and at age 50, you now have the opportunity to get the Shingrix vaccine. Shingles vaccine, Shingrix. And the pneumonia vaccine just became eligible for us. It used to be 65, and then they just changed it to 50. And this happens sometimes without even me realizing that they didn't update. I'll tell you that one happened because my 52, 53-year-old patient said, oh, so Dr. SJ, can I now get my pneumonia vaccine? I go, oh no, you're not 65 yet. She goes, Dr. SJ, I thought that they moved that up recently. I go, they did? I go, let's look it up. So we went to the CDC together, right at them on the computer. We looked it up together. I go, you're right. They moved this up and I wasn't even aware of it. When did they do this, And it had been like within that year. So it just moved up to age 50. And the Shingrix, here's a question for you. How many of you have had chickenpox when you were young? Oh, a lot of us did. I did not like that summer. That was a bad summer to have chickenpox, right? Oh, riddled with all those lesions, and yes. So what happened to that virus when it went away, when the lesions disappeared? Where did it go? Where in your body? And all the nerves of your face, nerves of your chest, nerves of your torso, nerves. It's sleeping there. Right? For some reason, at some point in our lifetime, we don't know why. Maybe it just got tired of sleeping. I don't know. Maybe you had a really bad pneumonia. I don't know. Maybe you have a lot of stress in your life that's really, with you. Something happens and it wakes up. Okay, so it wakes up and now it's one of those nerves that might be here, here, or here. It comes out, it's a burning sensation, and then it gets worse and more painful, then it crests over, and it's just painful. And it lasts about 7 to 10 days, and then we give you a viral medication, and if it gets a secondary infection with a lot of redness or swelling, then we give you antibiotics. Most of us can tolerate that, right? Not comfortable, but we'll tolerate 7 or 10 days of pretty much any discomfort. The problem is, once it goes away again, it's still there, right? But it went away. But now, in some percentage, about 20, 30% of the time, the pain does not go away. And so now people, and these are their words, not mine, they say it's stabbing, it's jabbing, it's burning, the pain that remains in that nerve where they came out. And that's what's called the neuropathy of shingles. It's that pain that stays there for up to a year. They live like that constantly, daily. And so I didn't want to be one of those people. So as soon as I turned that age, give it to me, right here. Give me that Shingrix, right? And it's a two-parter. So you come in one day, then 2, 4, 6 months later, you come in for the second one. Now, will you never have shingles? Of course not. Nothing's 0%, right? But less likely, hopefully, that you'll have a recurrence, right? And less likely that it will be severe, and less likely that you will have that neuropathy. And that's why we give the shingles vaccine if we can. Okay? Question?
Does it affect those that's never had chickenpox?
Well, that's always a question, right? We always think we didn't get a chickenpox outbreak, but sometimes we were exposed anyways, particularly if a certain age group of us that was around, and maybe your friend had it or your family member had it. Like I'll tell you, my father, who when we were that young, we never thought he would get it. Then later we realized he had gotten it from us, right? So sometimes exposure, and you never know. It's good when you remember, like I remember, getting that chickenpox. So it's good to get vaccinated if you can, just to make sure. Okay. All right. And then the next one. So 40s and 50s. The 40s used to be the controversial decade for do you get a mammogram or do you not get a mammogram? And then thankfully, next slide please, April of 2024, it's no longer controversial. We start screening at age 40. So we can start as early as age 40 for mammogram screening, and it goes every 1 to 2 years throughout our 40s and 50s, and then we stop somewhere in our late 70s, but that's what we do. And it is, again, it's for women who have an increased risk of breast cancer. We might do a little differently, but the rest of us between 1 and 2 years, every year is of mammogram. Okay? So I'd just like to emphasize that the only breast imaging modality consistently found to decrease breast cancer-related deaths is mammography. And it can detect cancer when it's really early, and really outweighs any risk that might be from the little radiation that we get. But after 75, we're not too sure about its benefits, and what I mean that is something called morbidity and mortality. Morbidity means complications from having that particular disease or that condition, and mortality is how many people die from it. So mammogram is the one that's been shown to decrease morbidity and mortality in women, and it's perfect. It is not, but it's the best that we have, and that's why we use that. Okay? So the next slide.
Question?
Yeah.
Sorry, over here. Do you recommend the AI enhanced reading or screening of the mammograms?
That's been around now for about a decade. And so basically that's called a 3D tomosynthesis. Say that 3 times. I thought seroptomus was hard, right? But 3D tomosynthesis. And so that is what they do. And I think that's most insurances, the last time I looked, in the United States cover that now. I remember when they didn't about 7 or 8 years ago, and I had to put another $100 down to get the extra 3D tomosynthesis view. I think it's great. So all the data that we have on morbidity and mortality is on mammograms. We have yet to collect the data about how much more does that enhance it. And so basically, along with the radiologist, it's a 3D generated, computer generated image of your breast. So now the radiologist reads the mammogram and then reads the 3D tomosynthesis, and we hope that they concur. Or we hope that this one found something that the mammogram didn't. So if financially you're able to put down that extra $75, $60, I would. But most insurances now, I don't have to pay that anymore on my insurance. It's kind of become part of the package. So that's a good question, the 3D tomosynthesis. Okay? So average risk is 1 out of 8 women throughout the course of their lifetime have a risk of getting breast cancer. If it's beyond that, moderate risk or high risk, and these are all the conditions, we don't have to go through all of them, but these are all the conditions that a woman might have. We'll go through one of them, like being an Ashkenazi Jewish individual, that increases your risk factor. Having a family history of breast cancer increases. If your mammogram says you have breast density that's very dense, because it's harder to view, that increases it. So you kind of go through all these things, and there's actually formulas that we use to see if a woman's risk is just average, 1 to 2 years, or are they increased? We need to talk. Maybe we should every year instead of 1 to 2 years, okay? All right, the next slide. So, mammography, not perfect. So I know that when a woman comes in to review a mammogram, and I tell her that she has a normal mammogram, right, didn't find anything, I know that there's about a 15% chance that we're wrong. 15%. So I know that about 85% of the time is really what is real. And about 50% of the time, it's just so small that it can't be seen, which is why we ask you to come back every 1 to 2 years. So if something changes, we have a chance to catch it. Something wasn't there before, something is there now, and it's 15%. And so we can then do an ultrasound if we need to increase the yield. But again, a mammogram itself is only 85% correct, okay? And then I always tell this to anyone who will listen to me, that if you feel a mass, or if your surgeon feels a mass, and if the mammogram comes back negative, don't believe it, right? You felt something. Your physician felt something. So the proper thing to do is to have your PCP, whoever, is to send you to a breast surgeon. And then the breast surgeon and you decide what to do if they feel something palpable that wasn't seen by the mammogram. And I've heard too many stories where women have been told to come back 6 months next year, and then something changes. And wasn't sure if I'd share this with you, but why not, right? So I am one of those 15% of the women. I am one. I go, great, it has to be you, right? You have to be another example of what's goes on in this world, right? But when I went in to get my physical exam for my pap smear, and the physician was appropriate in doing a breast exam, I always do a breast exam when someone comes in for a mammogram and a pap smear visit. And yeah, she felt something. I didn't know it was there. And I had my breast mammogram that afternoon. And so my mammogram was normal, right? But she felt something. And then I had the second diagnostic, which is a good point to share with you. A screening mammogram is 2 views. They press the breast tissue in 2 different views. That's called a screening. A diagnostic mammogram is because they felt something, saw something, whatever. You come back and they do additional views, and they hope that on additional views, it goes away. So that's a diagnostic. So I had the diagnostic right after the first one, and that was also normal. And then right after that one, they did a ultrasound, and that was also normal. So I had a triple negative, normal, everything's normal, but someone had felt something. The radiologist comes in and says, Martha, yeah, I know. when are we doing it? Biopsy time, right? And unfortunately, a week later, I get a call, I get a biopsy, and yes, I get the call, I have infiltrating ductal carcinoma. So I am one of those 15% that it does happen. But my physician knew, and the radiologist knew that they felt something. So within a week, I was getting a biopsy. That's what should be done. So if you have any friend out there in which they're telling them otherwise, tell them no, to go get that second opinion. Mm-hmm.
Being more of an advocate for themselves. So when someone does tell you something, what do you do to advocate to the next step to say, no, but I feel something, but I like to do this next step?
If you felt something, then you get a mammogram, right? If they don't see something because you felt something, then they do the next thing, the diagnostic, just like what happened to me. I had not felt that, by the way. I was totally oblivious that I had a breast mass. But if you feel something, and that's a story that I have with a patient that I had years ago, over 2 decades ago, and she called me because she was taking a shower, and she just felt something odd with her left breast, right? And I said, well, come on in, let's check it out. And we did, and I feel nothing. But she said, no, there's something wrong. I said, okay, let's send you off to get your mammogram, nothing, diagnostic, nothing, ultrasound, again, nothing. That was my first example as a doctor where that principle came in. And she was adamant, said, you know what, let's send you to the breast surgeon. So she went to the breast surgeon, all this within 6 weeks, right? And then he gives me a call, he says, Martha, I did another ultrasound in clinic here, and it's nothing bad, it's just something odd with the way the ultrasound is sending the signal back. It's just something different, so I'm just gonna biopsy that area. So he did, and of course, you know the story. So he calls me back and tells me that it was cancer. And I said, well, how come we didn't see it there? And he said to me, because the cancer on her breast tissue had just intertwined on the very surface of it. It hadn't had time to do this, which is when we see it. And then you have places where it just looks a little funny, Martha. So you have to have doctors believe you and listen. It's your body, and when she knew something was different. I couldn't feel it, but she knew, so I just listened and said, okay, let's send her to the next person, and he believed her, and he did it, and we got it right at the beginning, stage 1. Okay? All right, next.
Thank you.
Next to the next one. And so, come on to the next one. I think it's colon cancer screening. Please get colon cancer screening. Yeah.
I'm sorry, I have a question. I want to go back to the cancer. Is there some type of holistic way?
That's a tough one. So, things that have been associated with breast cancer, factors of that are unfortunately being overweight. So being overweight is a risk factor, and then for recurrence, it's also being overweight. So that's definitely an association that I can tell you about. Short of that, it can be genetic. It's just something happens in your lifetime that changes the cells that causes them to, become cancer. So it's kind of, but everything else, living a healthy lifestyle, a good diet, all those things, of course, they're going to help, right? So, yeah. All right, so back to colon cancer. And this is a little harder to sell sometimes because we got to get in there, right? We got to look, right? And so they changed the age from age 50 now to age 45. And this is because of a trend we saw over a decade ago in the medical field, that younger people were getting more colon cancer on the right side of their abdomen. So, ascending colon, transverse colon, descending colon, and then it goes out to the back. And so we saw that more and more younger people were getting right-sided colon cancer. We tend to have a little more left-sided when we're a little bit older. So they changed that to cover and to get those individuals who are younger. So it doesn't matter to me if you get a fecal test, a guaiac test. I didn't put the Cologuard up there, or a colonoscopy. So differences. So guaiac, FIT test, and Cologuard, they're all stool tests, right? Stool tests. So you take a little card home, you put a little stool on it, and you come back. The guaiac we don't use anymore in our practice. Why? Because the guaiac, if you had a nice big juicy piece of steak the day before, and you went to get a test and you had blood in there, you'd go, how rare was that steak? Is the blood mine or not? So that was why had a false positive. So we don't do those anymore. Now we do what's called the FIT test, the fecal immunotherapy test. Why? Because that test is an antibody against human red blood cells. So if that blood is there, it's human. And we need to go figure that out. The Cologuard is now being offered by insurances as well. The Cologuard, another stool test, there are different proteins that are being released by colon cancers, different types of proteins, like when we talked about the HPV virus, it has so many of them. Well, there's also several proteins that can come off colon cancer, and then they capture that. And that means, oh, you better go do a colonoscopy. Or you can just do a colonoscopy. Uncomfortable, yeah, prep is not great, whatever, but you get put to sleep for a little bit, you wake up, they've looked in there, and if there were polyps that were growing in there, unbeknownst to you, they get taken out. And then they get, sent to the path, to the lab, and if they're hyperplastic polyps, which means you're great, you're fine, nothing else is found, see you in 10 years, right? And then the interval is different depending on what they find, whether it's 3 or 5 years or 7 years. But most of the time when nothing's there, or hyperplastic is the word, then you come back in 10 years. So please do get that. It's something that's preventable, and I'll always remember my 38-year-old African-American male who died of colon cancer at age 38. That shouldn't happen.
So when it's just a protein that they find, what recourse do you have when it's just a protein?
Well, it's telling you that it's coming off a cancer. It's being made by the cancer. And the Cologuard is identifying those proteins that are commonly associated with colon cancer.
And so if that's the case, is the colonoscopy?
You have to go get the colonoscopy to look what's in there. Where is it? Cut it off, and then send it off to pathology. Yeah.
My other question, what is your take on colonics?
Okay, that's a big question. I think that if something makes you feel healthier about yourself and you trust the organization that's doing that for you, you can get a colonic. But a colonic is to remove the stool burden in your colon, right? And some of us just don't eat the proper nutrition to get things moving, right? And that has to do with fiber. I didn't think I was going to talk about fiber, but 1 minute on fiber. So as women, we need 20 to 25 grams of fiber a day to keep things moving, a day. And if you don't get that fiber a day, then you slow down. And that's one of the major causes for constipation, is we just don't get enough fiber. The other great thing to do is exercise. So exercise also things, keep moving in. And since I'm a very visual person, I tell my patients, to think of a toothpaste, right? You got that toothpaste out. What do you got to do to that toothpaste? You got to squeeze it. You got to squeeze it to get it out, right? So the intestine, the fiber, that's what the fiber does. It allows things to be squeezed, contractions to happen, and as they happen, then we get things out. So, but if it makes you feel better, then, that's fine. But every time they're going in there to clean it out, there's also a small chance of injury. Something might be perforated or something. So it's a risk for that. So instead, just have all that fiber and get things out naturally. All right, next. Okay, and then we'll go on to the next one. So after colon cancer, okay, so menopause. How many of us? We made it. We're here, right? So it is possible to get to the other side. But I love this definition of menopause, and it's from an Ethiopian anthropologist, right? So before moving to the United States, I was not aware that menopause causes depression or any other emotional or physical illness. I only knew that menopause was a time when women in my culture felt free from menstrual taboos. Okay, so why do we feel it differently here, right? So anyway, so let's go. So menopause is defined as 1 year with no menstrual cycle. Until that happens, you're in the perimenopause, which can be very uncomfortable to a lot of us, right? A lot of mood swings, a lot of what they call vasomotor, and I love that medical term, but I call it your personal summer, right? That is what the hot flash is. It's your personal summer, and you feel it, and you're like, oh. And so you have to adapt, you have to learn to, layer up and layer down. It gets cold, you get chilly, right? All that happens. That's your personal summer. Those are the vasomotor of hot flashes. But anyways, it's going to happen, and the average age of menopause in this country is 52 years of age. And these are all the menopause-related changes. I'm sure many of us have gone through this here, but the sleep quality gets poor, the mood changes. Oh my gosh, who did we become? The urogenital symptoms and syndrome of vaginal dryness and discomfort and all that, that's part of that change too. And our sexual well-being, our skin changes, our bone loss, we have a higher risk of coronary artery disease because now our estrogen, which was protective, is gone because it's dropping. And loss of estrogen causes a lot of joint aches and pains. And they forget to tell you that. And you're like hurting and this and that, and they don't listen that a lot of this is happening during that time. And one of the things I do want to talk about is bone loss. If we can go to the next slide. And go ahead and just bring this up because we already talked about it. And just go ahead and bring it in. This is about the hot flash. And I really like this picture. If it comes up, it's the woman going through her personal summer. Here she is, right? But anyways, bone loss. We forget to tell women that when you go into menopause, 1 year, no menstrual cycle, the next 3 to 5, 6 years of your life is when you have the greatest bone loss from your skeletal frame. And I think earlier, 2, 3 decades ago, we didn't quite have that information, so we didn't share that with women, so we didn't tell them, please stay active, please continue to walk, please do low weights to keep your skeletal frame, please take vitamin D, please take calcium, because if we can preserve a lot of that bone initially, you'll have less osteoporosis as we get further in life. So if you know somebody who's going through it, reach out to them, say, taking vitamin D, taking calcium, low weight, weights, lifting low weights, and then keeping your system walking, keeping it being active.
What can you do for your memory when you're going?
Well, it's part of everything. So there's not a specific thing I can tell you, but getting better sleep, right? Memory is such a convoluted thing because is it just the changes, or is there some psychological, social, spiritual thing going on, which is a conversation with a psychologist? Do we as women need medication? I think anything else is just being supported, right? That is actually happening to you. And it could just be taken care of by speaking with someone who's listening and saying, yes, that's true. You are going through these things. And it should get better. Unless there's an underlying problem. Is there a thyroid issue? Is there a depression issue? Are there really cognitive issues where they can do what's called a cognitive testing to see if there's actually changes in the way you think and you perceive reality? So all those things can be done. But it happens to a lot of us during that time. Yeah. Okay.
For the vitamin D, does it matter how many milligrams? Because I take 325 milligrams. Do I increase or stay at that level?
Your physician can do your level, and normal level of vitamin D is between 30 and 80. So if you're above 30, you're great, and that's normal. But I think if you're above 30 and you're going through the menopause, make sure you're 40 or 50. Maybe you don't have to be 80, but a little higher. So, and that could be either achieved by doing 1,000 units daily or 2,000 units daily. And if someone's really, really low, 10, 11, 12, 13, 14, they need 50,000 units every week for months to bring that back up. Because vitamin D that low causes confusion, causes depression, causes constipation, causes irritability, there's so many things, and your joints hurt. So when it's that low. So that's why it's important to do that. Okay, next. And this is just to show you that we're different as women, and shows you that the most prevalent sensation of vasomotor, your personal summer, your hot flashes, that African American women experience that stronger and for a longer period of time. And I think one of the disservice we used to do to tell women earlier is that, oh, these things will be gone. As soon as 3 to 5 years after menopause, these symptoms should be gone and you should be feeling great. And then you'd have women who are like, I'm 10 years out and I'm still having symptoms. And because the data said that that's what the case, you said, well, are you sure? But now the data's out. And the data says that yes, women can have menopause, the hot flashes, up to 12 years after. So now it just happens, and we can't always look at you and say you're going to be one of the ones that happens to.
Why are African American women having these symptoms?
So this doesn't tell us why. This just tells us that it's happening. And so there's still studies undergoing to see is there a Y in there, but it is that we feel it's stronger and a little longer. Yeah, and the least are our Japanese sisters, you know, that Asian sisters, they happen to have it less and for less frequent. Yeah, yeah. Okay.
And Dr. Sosa,
Uh-huh.
I want you to finish your presentation, and then we can go into questions
Yeah.
because we're taping.
Yeah, we've got about 2 more slides. We're really going to go quick. Okay. Osteoporosis, next slide. We talked a little bit about osteoporosis during menopause. Keep your bones healthy. This is a difference in bone that happens when we get osteoporosis. It gets really porous. Next. Let's just go through the different things I'll tell you. So when you go get your DEXA scan from your doctor, you want to know your T-score. Your T-score is your therapeutic treatment score. That's the one that's going to tell you if you need to have medication for osteoporosis, and that number is minus 2.5. And that's based on, this is 0, this is minus 2, minus 2.5. Above 0 is positive. So this just tells me, or tells your doctor, how far are you away, your bone health right now, to what you as a women were in their 20s and 30s. So it's how far are you away, and at minus 2.5, it's called osteoporosis. And you have a conversation. Okay, and the next one is really the last slide. And that's just, so what do we do? Don't smoke, please. That increases osteoporosis. Get calcium, get vitamin D. There are medications that can do this, cause increased osteoporosis. Some of them are the ones that I put in there, antidepressant, methotrexate, but you and your doctor should go over, are you on any of these medications that increase it? Sometimes you can stop it, sometimes you can't. Seizure medications, you cannot. And then reduce your alcohol intake, weight-bearing exercise, so running, jogging, weightlifting, etc. And then this is the last slide. Just summary points, things we've already talked about. Right? All the things we talked about, 20s, 30s, 40s, 50s, 60s. And the new vaccine that I will talk in this last comment is the RSV, the respiratory syncytial virus, is the new came back on the block. It's been around forever, but decades ago it was just the little children that got it, or the really elderly, 75 and above. In COVID, it reared its head up again. And so now if you're between 60 and 74 and you have asthma, COPD, heart failure, kidney failure, anything like that, you should have the vaccine, because if you get one of those things during that, the RSV during that time, you can make things worse for yourself. And at age 75, I don't even ask you, I just say, okay, it's time for your RSV, recommended 75-year vaccine, and we just give it to you at 75. It was a question, I think that was it. Mm-hmm.
Earlier, you mentioned that sometimes the cells can change over time, and I wanted to know what your take is on how trauma affects the body, specifically like childhood trauma.
Oh. There's actually a term for that in pediatrics, for trauma in general. Our health in general, a lot of it is inflammation, right? And there are some theories, especially in the pediatric population, that if we have early childhood trauma, it leads to a lot of inflammation in our body. And perhaps those are some of the reasons why populations grow up with more problems as they get older. So it is something to address, especially for children. And for us in this age group is to really understand, what is our life all about right now? And what is it, and you can do the last slide, and that's kind of to address your question. The very last slide, it's reminding us again, what is health, what is wellness, right? And it's about, one more, the last one. It's about, remember, not merely the absence of disease, right? It's about staying connected, self-care, exercise, meditation, I strongly support, staying connected, volunteering wherever you want to volunteer, and continue to explore new activities and figure out in your life, are there places in your life where we can decrease inflammation by getting counseling, by getting support? And that's a touchy subject with my patients, because no one wants to think that they need counseling, you know? But some of us do, and it's okay, and it doesn't mean it's forever. And I always say, look for a safe harbor. Look for a place that you're going to go and they're going to listen to you, only to you. And they're going to be there to support you and hopefully do something that's called cognitive behavioral therapy, which is finding strategies and problem solving to what your problems are now, right? That's what you need. You need that kind of counselor who's going to work with you to find what the problems are and to do solutions. And I'm going to tell you, I'll leave this will be my last commentary. I'll lead you with what my husband said one day about counselors and therapists. And he said that getting that counselor, that one that you connect with, it's like getting that next pair of really good shoes. right? I'm like, what? He goes, come on. You're saying it's too tight, it's too tall, it's too this, it's too narrow, not the right color, not the bow on top. And I go, you know, you're right. You're right. Which means it should give you the freedom that when you're meeting with someone and you don't connect, it's okay. Find somebody else. And if that doesn't work, it's okay. Find somebody else until you connect and you know that you're in a place where you are taken care of and you're being listened to. That's it. Thank you. Whirlwind.
Yes, thank you, Doctor.
You're welcome.
Beautiful. Thank you, Dr. Sosa. Amen. Absolutely beautiful. And I'd like